Hello and welcome to Radcliffe Cardiology's webinar supported by Philips Healthcare. I'm Dr. Christopher Cook, Clinical Editor for the Radcliffe webinar series, and I'm delighted to be joined live by Professor Javier Esquined from the Hospital Clínico San Carlos in Madrid. Professor Esquined is going to be talking to us today about the intravascular ultrasound-guided management of diffuse stenosis. Now, we are all aware that the complexity of coronary artery disease is ever increasing. This means we have to develop an understanding of how best to treat diffuse coronary artery disease. During this webinar, Professor Esquined will outline for us why diffuse disease poses such a treatment challenge, and he will teach us how IVUS can help in procedural planning and in the attainment of an optimal PCI result. Now, before we begin, just a quick note to our audience, you'll have the opportunity to ask Professor Esquined questions via the text box on your screen throughout the course of the webinar, and he will answer as many as possible at the end. Okay, so I'm going to stop talking now and hand over live to Professor Esquined to begin his presentation.
Thank you very much, Chris. Welcome to this webinar on intravascular ultrasound-guided management of diffuse disease. Thank you for the introduction, Chris. As it was mentioned, I think we are dealing with a topic of great interest for all of us who are involved in clinical practice. As you know, is obviously the diffuse disease is perhaps the most extensive manifestation of coronary atherosclerosis. It has been associated not only with poor outcomes in patients that have, say, coronary artery disease, untreated coronary artery disease, but also, of course, for those patients that undergo a primary PCI or any form of coronary intervention. Now, for the interventionist, diffuse stenosis or diffuse coronary artery disease present a unique of a number of challenges that can be addressed by using intravascular ultrasound. First, we have to remember that during atherogenesis, we have a remodeling of the vessel, and that judging this from the angiogram is not possible. We can have either a positive remodeling of the vessel, that means enlarging of the total vessel area as the narrowing of the coronary artery happens, the lumen of the coronary artery takes place. Or, on the other hand, we can have negative remodeling of the vessel, which has been associated to very common conditions like, for example, diabetes. It is rather unpredictable to know if a vessel that is narrow actually has compensatory or negative vessel remodeling. Now, the second challenge is the identification of disease in segments that appear angiographically normal. We typically try to identify segments of the coronary artery that are devoid of disease, because we know from previous evidence that if you land with your stents in an area that has extensive atherosclerosis, and particularly if you have atherosclerosis that is lipid-rich, you have more possibilities of having a complication, and also more possibilities of developing a stent failure in the long term. And finally, it's of course very important to make sure that we have achievement of optimal stent expansion in terms of luminal dimensions and stent position in patients that have diffuse disease. And this is more complex because, of course, we are treating longer coronary segments, and that increases the possibility that in one of these particular segments we have failed in achieving adequate vessel expansion or apposition. Now, the very definition of diffuse stenosis or long stenosis is a matter of discussion. I mean, conventionally, some documents have used the definition of more than 20 millimeters in length. But if you look to the literature, you can see that those studies that have used different definitions came always with the same type of conclusions, that the longer the stenosis, the more extensive the narrowing of the coronary vessel, the more possibilities you have of having MACE in the long term after stenting or target lesion failure, or that you have also more possibilities of having stent thrombosis, even very late stent thrombosis. Now, what we'd like to share with you is basically a structured approach to the diagnosis and IBUS guided management of long stenosis of diffuse disease, and which also takes into account the information that you can obtain with intracoronary physiology. And what we would like to share is this algorithm that has been developed at our institution, at Hospital Clínico San Carlos, that reflects our practice. It reflects as much as we can all the evidence that we have obtained from the bibliography, but that in a way, again, is simply something that we would like to share with you. It has not been formally tested, and actually I do not believe that these type of algorithms will ever be able to be tested, because it is extremely difficult to obtain evidence on how an algorithm of these characteristics truly modifies the long-term outcome. But as I say, it is supported by individual studies that have provided valuable observations on how specific mechanisms of stent failure or long-term outcomes are influenced by diffuse disease. So if we start by step by step, we walk step by step into this algorithm. We start with what it is, the plaque assessment with intravascular ultrasound. We typically try to understand what is the structure of the atheroma that makes this diffuse narrowing, and we may consider whether you have superficial calcium, particularly if you have a neighboring distribution of calcium around the lumen. In many occasions, when you have this particular pattern of calcification, you are not able to advance your IBUS probe completely through the stenosis, but that actually provides also some clues that you have an indication for rotational atherectomy or any technique that can actually address extensive calcification. We have now upcoming techniques like, for example, the use of shock waves for treatment of calcific stenosis, and there are other techniques in the pipeline. So basically, again, the information that you obtain, even if it is not over the whole stenosis, over the whole diffusely diseased segment, can be very valid to anticipate what will be your challenges and what will be the next step in terms of treatment. You can consider, as I mentioned, also cutting balloons, or you can anticipate that we need to use techniques able to prepare the plaque for subsequent treatment. The next thing that you will have to do is to, once that you are able to do this, and sometimes what we do is even to perform consciously dilatation with a small balloon, a 2.0 balloon, for example, and then to perform again IBUS once that you are able to advance the probe, is to obtain the answers to very important questions. And basically, we are referring to the landing zone, where you plan to land with your stent, in order to anticipate what will be the length of your stent. So we're going to see this in detail in the next slide. Now, the landing zone is one of the most important aspects of choosing the right landing zone. Is one of the most important aspects of performing PCI guided with IBUS in diffuse disease. You should look, of course, for the distal segment that has the minimal plaque burden. Whenever it's possible, whenever you have performed intracoronary physiology, you try to use information gathered in the pullback to try to see if the segment that you aim to treat really corresponds to the segment that accounts for most of the hemodynamic impairment caused by the stenosis. And now with upcoming techniques like, for example, the IFR pullback, particularly with IFR pullback co-registration with angiography, you can really obtain a beautiful hemodynamic map of the coronary vessel, and to understand which segments deserve treatment in order to normalize, as I say, the vessel hemodynamics. But this information will have to be integrated also with the information provided by IVUS regarding which is the right place to deploy your stent in terms of plug burden. Now, typically what we do for this is we pay a lot of attention to distal luminal diameter of the vessel. The measurements we do in the distal part of the vessel tend to be much more at the level of the luminal contour than to the external elastic lamina. The reason for that is because you aim to deploy your stent without stretching the distal segment. Remember that you stretch aggressively the coronary segment, you immediately will trigger vascular repair reaction that will enhance or will generate a neointima, stenosis. So typically what we do is we try to identify a segment that is devoided as much as possible of atherosclerotic plaque, and again with a stent size that allows the apposition at this point. But that is not enough, of course, because you really have to do the same with the proximal segment. This is something very important. And this is due to two different aspects that have to be discussed. First is that the fact that you're treating a diffuse disease means that you typically will have different vessel diameters in the proximal and distal end, which is quite normal. Many of these occasions you have small branches happening in the disease segment that account for a tapering of the vessel. And some cases this change can be dramatic to the point that a specific stent that you choose for on the grounds of a distal landing zone can be not expanded or could not be expanded to reach the diameter of the proximal landing zone. The typical situation, of course, is when you have a diffuse stenosis that comes up to the left main. That is one of the aspects that is important to take into account. What type of stent are you going to select that can be landed safely in the distal chosen landing zone, and that at the same time can be expanded to reach the dimensions of the proximal landing zone. The second is that, as we discussed before, you don't want to choose an stent that is bigger than the vessel size in any of the segments along the diffuse segment. So basically, saying in other words, if you have a negative remodeling of the vessel, the stent that you may choose may be too aggressive to really expand the vessel to the diameter that you may judge on the grounds of just the distal and proximal luminal dimensions. So this is a very typical situation for this is when you have a situation of a chronic total occlusion, for example, where in many occasions you have remodeling, or as I mentioned before, you have certain pathologies and diabetes and renal patients where sometimes you have this process of negative remodeling that really complicate or make advisable to not to be too aggressive in the selection of your stent. So it is something that really contributes to the safety of your decision making. Once that you have this information in hand is when you really have to integrate, the different pieces of information you have as to decide whether you will go for a single stent, overlapping stents, whether you will have, when you choose a stent dimensions, and of course to choose what are the landing zones. As I mentioned before, if you are using also image co-registration with angiography, this aspect is greatly facilitated. This slide shows a different part of the algorithm that we discussed before that has to do with the post-PCI assessment and optimization of stenting with IVUS. So basically, we first start with assessing the distal and proximal vessel, and we try to assess if we have edge dissections that complicate luminal lowering. You have a dissection that really extends in a big arc of the coronary vessel, or when you have a big flap that is really evident in echocardiography in IVUS. Remember that in this aspect, IVUS is much less sensitive than OCT, for example. So when you really are able to identify with IVUS big dissections, is that typically it's a dissection that has to be considered when you have to treat or not. Minor dissections that do not require treatment typically are not visualized with IVUS. It's exceptional. Sometimes you can use also chroma flows, this specific image protocol that allows visualization of the lumen to identify big dissections with IVUS. Now, regarding the stent assessments, we have discussed already how to assess the proximal and distal vessel. Regarding the stent assessments, we now concentrate in looking to proper expansion of the stent and a position. As we mentioned before, in diffuse disease, one of the problems we have is that it is rather easy that in a specific spot you have lower expansion of the stent, and you should be concerned in general if the luminal area in these locations is less than 2 millimeters squares in area. Again, all this has to be in perspective, put in perspective, has to do also with the location of the segment that you are working. If you're working in the proximal segment of the vessel or in the mid segment of the vessel, and also on the characteristics of the atheroma that you have in that particular part. A particular attention should be paid to areas of stent overlap, because these areas do require typically additional post-dilation. And remember that these are some of the areas that have been associated with the development of stent failure, both in terms of stenosis and also potential for stent thrombosis if the stent overlap coincides in an area where you have a stent under expansion. So, based on this information on IVUS, typically what we do is we optimize selecting non-compliant balloons. Typically, for this, we can of course take the concurrence of stent imaging protocols included in your angiographic system, like stent boost, for example, or stent boost live. And very frequently, most frequently, what we do is to reassess with IVUS to ensure that the actions that we made to correct these anomalies or say aspects of suboptimal implantation of a stent are corrected. Again, it is just a matter of choice or expertise to use concomitant techniques like stent boost that sometimes you see may indicate that the corrections that you have made have been successful, and therefore, in that case, you may not require to use IVUS. One aspect that is important, perhaps is not included now in the slide, but we could comment, is in long segments that are in tortuous, with a tortuous anatomy, sometimes you have to be careful if, for whatever reason, the IVUS has difficulties in advancement. Remember that contemporary drug-eluting stents are very delicate structures that are not designed to be handled with longitudinal forces. So if you always have to keep this in advancement in mind, and if you have a difficulty in advancing your stents, you may remember that putting an excess of strength or force to your IVUS could lead to stent deformation. But it's something that you also have to keep in mind. Here we have some cases that basically illustrate this type of situation. So you have here the pre-PCI assessment of this long LAD stenosis, in which IBUS demonstrated that the distal part is pretty devoid of atherosclerosis. In the proximal part, you can see that there was about a 50%, less than 50% atherosclerotic burden. So based on this information, we choose, the stents using some landmarks that could be useful, like for example the septal branch. This is very important. Sometimes what we do to get better landmarks is to put an additional guide wire in one of these small vessels. It can be a septal, it can be a diagonal, because the guide wires will be much easier to identify when you are imaging with IBUS. If you are using IBUS and geographical registration, this is not a problem any longer, because you can see very clearly the relationship between angiographic anatomy and your findings. Now, the bifurcation here was chosen as a landing zone for the stent, because this also provides an extra safety mechanism for landing with a bigger stent. Remember that the polygon of confluence of the bifurcations in a way provide an opportunity for landing with a say relatively large stent without damaging the intima of the vessel. We were careful in this particular situation. As you will see, this is one of the examples where the information that you obtain on the external elastic lamina over the narrow segment, as you see in panel number 2, you should not exceed this particular size when choosing your stent. So particularly after choosing, a 3.035 millimeter everolimus eluting stent and optimized with a non-compliant balloon, we obtained a very good result that you obtain at the right. So again, an example that illustrates how to take into account distal and proximal landing zones, the characteristics of the vessel in the segment that is in between. Now, this is what you're seeing here is another case. In this particular case, what we're seeing this very long diffuse stenosis in the LAD. You can see from you're just seeing the IBUS images obtained over this particular segment. Now, in the pre-PCI assessment, we are looking to this area of stenting in this particular vessel. And as we will discuss later, in stent stenosis is a subset of long stenosis that deserves particular attention, because you really have to understand the characteristics of the previous PCI in terms of whether the stent was fully expanded or not. In this particular case, we have the information obtained from pullback and from an IFR pullback. You can see this in the mid panel, and it was possible to understand that there was a particular segment of this previously stented segment that accounted for all these hemodynamic impairment. So you have to concentrate in this particular segment. So this is an example that wanted to illustrate how you can have a synergy between intracoronary physiology, in this case through IFR pullback, and the nature of stent failure that you are addressing and causing this long diffuse stenosis. Now, this is another case where we are seeing this assessment again with IFR in this in the vessel. You're seeing here basically physiological assessment in the circumflex vessel, also co-registered here with angiography. We are seeing also the IFR co-registration in the LAD. So in the LAD, what we noticed is the pressure drop was localized very proximal, very close to the ostium, but due to the lack of a lot of diffuse disease that you can see in the panels here, we have to choose a much longer stent for this particular situation. So basically, what this is a very good example of how, in some situations, an stenosis that looks relatively focal constitutes actually the tip of the iceberg of a much diffuse disease that requires treatment with a much longer stent. So once that we choose the proximal landing zone, we decided, of course, given the very austere location of this stenosis, to land in the left main, and then we choose a 4.0 22 millimeter stent that was deployed with a T technique in the circumflex. And later we performed an optimization with a 4.5 millimeter balloon with an excellent result. So those are examples that basically illustrate the relationship of the information that we obtained with both physiology and IBUS to apply the algorithm that we described before. I mentioned before that there are some special considerations regarding diffuse stenosis. I think that chronic total occlusions is one of these situations, typically when in many occasions we open the occlusion and we have a very long segment of diffuse disease, which provides a challenge to interventional cardiology in terms of if you have to treat or not. Here it is of paramount importance to perform, as I mentioned before, a long analysis of the segments. Chronic total occlusions, it is not seldom what happens is that the vessel has undergone negative remodeling simply because there is a lack of antegrade flow. One of the reasons was, with this information in hand from angiography, we should certainly refrain from doing any type of maneuver, understanding that once that we restore antegrade flow, this vessel will probably remodel again to achieve bigger dimensions. It is also, of course, important in that situation because in some occasions you may disclose that part of this narrowing can be due to a different cause related to the procedure, for example, to a vessel wall hematoma. That also may happen more frequently in the case of recanalization of chronic total occlusions. With bioresorbable scaffolds, I think it's, again, very important when you're, even now with that we are no longer using the absorbed scaffolds, but we have magnesium-based scaffolds. I think something that is really important is that potentially the benefit of these devices is the treatment of longer coronary segments because they will resolve later. But again, as discussed before, it is really, really important to ensure that these scaffolds are properly opposed to the coronary vessel. Remember that it was the PSP recommendation that was generated for scaffolds was based on the association between having malapposition of scaffolds and stent thrombosis that was clearly noticed, or even improper, say, expansion of the vessel due to misunderstanding or improper understanding of the nature of underlying disease, and therefore leading to improper plaque preparation. Stent overlapping, we already discussed the importance of ensuring that this is not an area where you have improper expansion and the association with long-term outcomes. And the case that we have shown on in-stent stenosis demonstrates the importance of understanding what was the result of the index procedure and the correction of this before proceeding with a new, with either implantation of a new stent or use of drug-coated balloons. So, in conclusions, for this presentation. We have to be aware that diffuse stenosis are lesions that are associated with higher rates of stent failure. That relying only on angiography may lead to inadequate procedural actions, and that this may affect the short and long-term effect of PCI. Once that you start using IVUS in this situation, well, it really will help you to benchmark your interventions, and will really help you to perform a better planning and guidance of PCI in this long stenosis, particularly when you complement it with physiological information, often with pressure vessel mapping. Again, the algorithm that we propose is tries to integrate as best as possible the information that has been obtained in the individual trials in a pragmatic fashion. We did not want to say fixed recommendations regarding like any of the criteria that have been proposed for obtaining maximal expansion, etc., etc. I think that once that you obtain the information with IVUS and you circumvent the limitations of angiography, it becomes clear to you that you have much better chances of obtaining a better optimization of your PCI than when you are using angiography alone. So with this, I will conclude my presentation, and I really look forward to your comments and discussions.
Great. Well, thank you, Professor Esquined, for a fascinating presentation. And we've had a great response from our audience. So if it's okay with you, I'd like to dive straight in with some questions. So the first question is in the category of general IVUS questions. And the audience member wants to know, what is the penetration of IVUS use in your own clinical practice? And how do you think that compares with the wider global use of IVUS?
So what I will say is that depending on the indication or the anatomical subset, etc., the use of IVUS in our institution overall, taking into account all my colleagues, all the operators, change is varies a lot. I would say that in left main, for example, is probably about 80% of the cases. I would like to say 100%, but there are some situations where still you will not use IVUS for one reason or the other. But certainly, saying 80% means that that we assume that in the left main is in a scenario where it is extremely important for ensuring understanding the context where you are performing PCI, and even more important, ensuring that you have obtained a very good job. It is true also that the eye of the interventionist gets re-educated with IVUS. Typically, the interventionist that used IVUS regularly will always finish a left main with a 4.5 5mm balloon for optimization. This is typical because you see that these are the figures that you see come to your mind every time and you see the pitfalls that were committed. So left main is one of the scenarios. Secondary scenario, of course, we have been discussing now diffuse disease. This is a very important scenario as well. Probably I would say that in this scenario, the use is about 40%, 50% of the cases, depending a bit what it is. In many cases, IVUS is restricted. If you are not able to image baseline, it will be restricted mainly to optimization of the stenting once that it has been performed. In a stent failure, for example, I would say that imaging is about 80% of the cases, very high experience. And we believe it is really mandatory to understand what happened in the previous intervention, and then to correct any problem that you have there before proceeding. And it's very important, again, to ensure that you have obtained a very good result. And CTOs, we typically use CTOs I would say 70% of the CTOs. Remember that in CTOs, IVUS is sometimes simply required to guide your proceeding. If you're making a retrograde case, and you are performing what it is called CART. In this situation, you cause extensive dissection that precludes the use of antigrade injections. If you make an injection, you will cause a dissection that will extend and you will ruin your case. So that means that for very important segments of the PCI in CTOs, you have to be guided by IVUS. And there are other situations, like, for example, IVUS-guided wiring of osteostenosis, where IVUS is instrumental. So those are some scenarios, where we the use of IVUS is really much more marked than in others.
Great. Well, thank you for that. So that's a really complete answer, explaining that in left main, diffuse disease, stent failure, and also the CTO population, that really IVUS helps plan and optimize your procedures. Now, what do you think are the barriers for people to use IVUS at the pre-procedural planning stage?
So the pre-procedural stage, unless you generate, say, unless you enter into this circle of benchmarking your results, of understanding that choosing the length of stents is something that simply cannot rely on eyeballing, but should be based on much more objective reasons. Once that you enter into this, once that you see, you dare to go into the vessel and see what it is there, it's when you really start to understand, and to use more frequently the IVUS in this situation. So I think that it's sort of, I would say, virtuous circle. Once that you start using it, you use it more and more, because you benchmark your results. When you see that beautiful angiographic result actually is associated with incomplete apposition of the stents, for example, when you see that there was very marked under expansion of your stent, then is when you start really using IVUS more frequently. So I would say that those are, in a way, the culture, so to speak, will be the first obstacle. Unless you modify your culture, unless you dare to re-examine what you do, you will not start doing this. I guess that in some environments, costs can be an issue. But I don't think that this is an excuse, because the cost of, the overall cost of performing an intervention that it is suboptimal, will be much higher in terms of stent failure, in terms of than if you really understand what happens and you do a good job. We do not have figures, of course. I mean, this is one of the big problems that justify the use of IVUS based on recommendations on cost efficiency, etc. We have a lot of evidence, scattered evidence, good trials, etc., that demonstrate that there is a benefit in using IVUS for your patients. But yet, given the ease of performance of PCI and the fact that it is quite easy that the patient leaves the cath lab and leaves the hospital without an evident complication, you don't see, and we have to understand that as physicians, we require the information provided from big populations of patients included in the studies to understand that we can optimize our performance and to deliver better care to our patients. That's my understanding.
Great. That's a fascinating answer. Thank you. So do you think co-registered IVUS systems allow for more accurate stenting?
Oh, definitely. Yeah. This is I think that this is something that is going to really contribute to adoption of IVUS. I'm completely sure. And that's the reason is because at the end of the day, we still rely in angiography to perform what I call angiography-based decisions. Where do I land my stents? Where do I post-dilate, etc., and this is a fantastic way of facilitating something that that requires some skill. If you are giving a set of intracoronary images and an angiogram, it requires some skills to be able to say, well, this is I have to treat this specific segment or that specific segment. Sometimes you can be a bit misleading. IVUS angiographic registration really facilitates this a lot. I think that, as you know, we have now some dedicated systems. The system by Philips is Sync Vision is very good, fantastic. But also, for example, now we have systems for looking to the silhouette in the arteries that you're interrogating, what is called dynamic road mapping, that allows, when you are performing a pullback of your IVUS, to understand which is the location of the imaging sensor and within the coronary artery. So I think that co-registration is going to be much easier in the future. Co-registration will be facilitated greatly by the road mapping protocols included routinely in the angiography system. You will be able to understand where you have your IVUS, what you are imaging, and to understand exactly which part of the vessel requires a specific action.
Well, there's a fantastic technologies. And do you think we'll ever move to the stage of being able to try register coronary physiology data with IVUS data and the angiogram?
So this is already feasible with the Sync Vision platform. You can perform what we call tree registration, by which you can integrate the information obtained in the physiological angiographic registration with the IVUS angiographic registration. So basically, the main topic that this addresses is first, to make sure that you treat what you have to treat in order to improve the vessel hemodynamics, as we said before. You want to restore the functionality of the epicardial vessel as a conduit. You have to understand that, just getting an FFR or a single FFR or IFR measurement can be very misleading. You might end up by placing your stents in the wrong place and therefore not achieving, not relieving the hemodynamic consequences of the obstruction. But once that you have done that, you are faced also with the problem of, okay, how do I stent this safely? Where do I land? How can I, based on this information that I have from imaging, how can I optimize or make decisions regarding the length, the landing zone, etc., that most likely will ensure a very good long-term or short-term and long-term outcome as well. And that's the reason because, sometimes, like in the case that, one of the cases that we show, you may have, hemodynamically speaking, a very focal stenosis, but from an imaging perspective, you may need a much longer stent. So, in a way, this puts an end to the discussion about the so-called spot stenting strategies. I mean, the spot stenting strategy was something that was used in the past based on purely angiographic criteria. Nowadays, we tend to incorporate the information that we have both from physiology and IVUS in terms of deciding the length of the stent and where to land at the stent.
Great, thank you. And so we've now got some questions from the audience which are more general towards the management of diffuse disease. And so one of the questions is, do you manage the antiplatelet regimen the same in patients with long segments of diffuse disease that have been stented?
Thank you. That's a very good question because, first of all, remember that one of the reasons because you try to optimize, when you optimize deploy the stent in an area of diffuse disease, what you are also doing is you are decreasing the dependence of the patient on double antiplatelet treatments. So this is a very important aspect. Overall, we lack information on whether patients that have diffuse disease are better off in the long term with DAPT in terms of reducing a potentially higher risk of thrombosis. overall. I'm not talking only on patients that have been treated with PCR. I think that this is, in any case, our approach is always to consider the risk of the thrombotic risk and the bleeding risk as part of the overall strategy. If we have a patient that has potentially a moderate or high bleeding risk, we will again enforce the use of IVUS to make sure that you obtain a very good IVUS result, optimize it to the better, to ensure that if this patient, has any type of unexpected bleeding events before you expect it, before you will go to single antiplatelet treatment, you could safely go to it. And again, it would be great if in the future we get specific information regarding patients that may have indication from prolonged double antiplatelet treatment based on the information obtained with IVUS. For the time being, we don't have that information.
Great. Well, thank you so much, Professor Esquined, for answering our viewers' questions. It's been a real pleasure having you with us today, so thank you very much for joining us.
Thank you very much for joining. Bye.
So that was Professor Esquined speaking to us live from the Hospital Clínico San Carlos in Spain. You can find out more about Professor Esquined in the link under this video. It just remains for me to say thank you, our audience today. As ever, we would be very grateful if you could please rate this webinar using the star rating system on your screens. If you have enjoyed this learning experience and want to listen to our other webinars, please turn to the Academy section of our website at radcliffecardiology.com/academy/webinars. So that's all from me. Until next time, thank you and goodbye from Radcliffe Cardiology.